Hello, everyone. Welcome to today's webinar, Biomarkers and Ovarian Cancer Treatment, What You Need to Know. I'm Maggie Nicholas-Alexander, the Senior Director of Gynecologic Cancer, Patient Support and Education at SHARE. Before the presentation begins, I'd like to tell you about SHARE. We're a national nonprofit that supports, educates, and empowers anyone diagnosed with breast or gynecologic cancer and provides outreach to the general public about signs and symptoms. Because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, support groups, and our helplines, please visit our website at sharecancersupport.org. Now we have a few housekeeping reminders for you. All participants will be muted during the presentation. Once the speaker finishes presenting, we'll begin the Q&A discussion. Please submit any questions through the Q&A section at the bottom of your screen. Remember that our speaker cannot give specific medical advice, so please keep your questions general. We also offer closed captioning. You can enable this feature by clicking the live transcript button at the bottom of the screen and selecting subtitle option. This webinar is being recorded. In a few weeks, we'll share the recording with all registrants and add it to our website. I'd like to hand it over to our speaker, Dr. Boyd, who we are so excited to have here today. Dr. Boyd, the floor is yours.
Thanks so much, Maggie. And good afternoon, everybody. It is such a pleasure to be here with the SHARE community today, a group that has given so much back to so many of our patients. So this is my humble way of thanking you for all the great work you've done over the years. Without further ado, I'm going to share my screen. Oh, hold on. Yep. Okay. All right, let's get going. We don't have too much time and there is a lot to cover. And I'd like to make sure you guys come away with all of the information that you can today. I don't have any relevant disclosures. So briefly, we're going to talk about what biomarkers are, how we use them. And essentially, we use them both in upfront treatment for ovarian cancer as well as in recurrent disease. And they are critical for a new class of systemic agents called antibody-drug conjugates, who we're going to talk about a little bit in this talk as well. So what are biomarkers? A biomarker is a biological substance made by the body or the tumor that gives information about the cancer. So that's a pretty basic description. And biomarkers can be important really throughout the cancer journey. Certainly something we've looked at for screening and early detection. I could give a whole talk about biomarkers and screening and early detection. And one of the biomarkers we know and love most, CA-125, I'm sure is something you guys have heard about before, but that's not what we're here to talk about today. But certainly that's a biomarker. Other biomarkers can confirm the diagnosis. They can help with the prognosis or give us a sense of how concerning the cancer is going to be. They can be very helpful in terms of choosing effective maintenance therapy to consolidate your initial treatment for ovarian cancer. And they're also critical to decide what treatments you can use if you recur. So today we're going to focus on the last two of these as we're talking about treatment as it relates to ovarian cancer. So as I've just said, we want to look at biomarkers certainly at the first diagnosis and then if the cancer should come back. So at the initial diagnosis, we are particularly concerned about two tests, one genetic testing and also HRD testing. These are interrelated, and we'll talk about that a little bit as the discussion goes on. And then when we look at recurrent disease, right now there are several tests that are of importance, but today I'm going to talk about HER2, folate receptor alpha, and just general molecular testing. We'll go into that at length too. So genetic testing and molecular testing are both really important to determine what we call HRD, homologous recombination deficient status of the tumor. And why this is critically important is that a tumor that is HRD is likely to respond to a class of medications called PARP inhibitors. And I'm sure many of you already know what PARP inhibitors do and that they are of real benefit to this certain patients immediately after completing initial chemotherapy. So close to 50% of ovarian cancers are HRD. So if you look at this diagram, this is basically looking at all of the different types of ovarian cancers. We call it ovarian cancer, but that's really an umbrella term for a series of different cancers and different cell types that have different molecular drivers, meaning they arise from different mistakes in the genes in our body. And really, if you look at this line, at least to here, we think are almost certainly HRD and possibly here as well. So why does this matter? So this is one of the first big trials looking at PARP inhibitors in patients after completing primary chemotherapy in their ovarian cancer. This was called the SOLO-1 trial, and it looked at one of the PARPs. It's called olaparib, and it basically randomized people to, again, at the end of chemotherapy, you either got a PARP inhibitor, olaparib, or you did not. And look at how people did. So the people who got the olaparib are here in blue, and the people who did not are in red. And if you see here, what we look at often is how the progression-free time, so the time before the tumor comes back. And at 50%, that means half of the people it has come back and half of it has not. And for those patients on olaparib, they haven't even at the end of, this is a 5-year trial, they haven't reached 50% after 5 years. Whereas the patients who did not get the olaparib got to 50% survival after about 14, just before 15 months. So a really big difference here. But what's critical here is that only patients with known BRCA mutations were enrolled in this trial. And we know as a definition, BRCA patients who carry these pathogenic mutations have HRD tumors, the initial definition of HRD. So this is another way of saying that if you have an HRD tumor, you're going to respond really well to a PARP inhibitor, in this case, olaparib. And we see this is a great review. Here's the olaparib trial I just showed you, and this is a fancy way of looking at a number of trials. And this diagram is showing you if you're over on this side of the diagram, it means the PARP inhibitor worked really well. And if you're over on this side, it means it wasn't that helpful. And what this tells us, I'll summarize, is that for patients who are HRD, they're on this side of the diagram, whereas those who are unknown or wild type, which means not HRD, they're much closer to this part of the diagram. So again, your response to the PARP inhibitor really does depend on your HRD status. And that's across all PARPs, not just olaparib, but the other types as well. So as a result of that, everyone with a new diagnosis of ovarian cancer should get genetic testing. Of course, genetic testing has many benefits. It can tell you about other cancer risks you yourself may have. It can tell you about cancer risks that other people in your family may have. But it also tells you if you are HRD status with your tumor. Now, if you test negative for genetics, meaning you do not have a BRCA or 1 or 2 or any of these other mutations, so I listed them here, which are associated with HRD status, then you need to get a separate HRD test to assess what your HRD status is. Now we'll talk a little bit about recurrent disease and what biomarkers we're looking at that juncture. So I'm going to start talking about molecular testing. Now, this is just an umbrella term that describes a test that looks at the pathways a cancer uses to avoid cell death. Now, cancer itself is an umbrella term. A cancer cell generally has the capacity to do two things that our cells should not do. It has the ability to divide unstoppably, and it has the ability to move throughout the body. Our normal cells cannot and should not do this. So each cancer has figured out a way to avoid the normal stops in our body that keep our cells from dividing and keep our cells from moving. And the pathways it uses to gain this function are the ones that we're looking at for these molecular tests. And these are just different types of molecular tests that may be available, and we won't go into that today. It's a bit technical. So there are many cancer centers and companies that offer molecular testing. At NYU, where I am, we have a PACT test. MSK has an impact test. And then there are several companies, I've listed two of the most common here, Foundation Medicine and Myriad, who have their own tests. So some of these are kind of in-house within the cancer centers where you seek treatment, and others of them are just separate companies. And this is actually a picture I took from a Foundation Medicine report, because this is a Foundation being one of the most commonly used. And what we see here is the report goes through, looks at the type of tumor it is. In this case, this patient is HRD, and then looks at all the changes in various genes that are identified. What makes this testing particularly important is that it looks for actionable findings, meaning, are there changes? Are these pathways druggable? So are there drugs that have proven benefit in patients against these various pathways? So in this case, this patient has changes that are consistent with an HRD status, as it says above here. So here are all of the PARP inhibitors that are listed, because as I just said, we know that PARP inhibitors are impactful for patients with ovarian cancer. And if other findings would lead to different therapies as they were relevant. So molecular testing and genetic testing is not the only way to find important biomarkers. There are some tests that are a bit simpler that we've been using for years that can also do the same thing. And one of them is something called immunohistochemistry. And that's where we take the pathology and we stain it to look for specific antibodies and identify different proteins that are exhibited in the tumor. Usually that staining pattern is graded from a 0 to a 3, depending on the molecule that we're looking at. So this is important for two other actionable biomarkers that we are using right now in ovarian cancer. One is folate receptor alpha, and the other is HER2. We're going to talk about folate receptor alpha first. And briefly, I'm going to talk about antibody drug conjugates. So the concept here is that unlike standard chemotherapy, which goes throughout the body, an antibody drug conjugate has an antibody, there's a whole antibody, that is specific to a target that should be found on the tumor more so than normal cells in your body. Once it gets to that marker, it then releases chemotherapy directly into that cancer cell that it bound to. So Mirvetuximab soravtansine is the first ADC approved in ovarian cancer. The trade name is Elahere. And this looks at or binds to folate receptor alpha, which is present in about 80% of ovarian cancer cells. And I'm going to go through this fairly briefly, but the trial data behind MIRV, call it MIRV for short, showed that you had to have a high expression of folate receptor alpha in order to get a benefit, which makes sense. Again, it's an antibody that's directed to that target. So the more of that target you have, the better this drug should work. And that's how it does work. And so ultimately, the FDA granted approval to MIRV for patients with ovarian cancer, but only those with high FR alpha expression. And that's defined specifically here. You have to have enough, over 75% of staining with a high intensity on the immunohistochemistry, as we discussed before. The other biomarker that we can look at as actionable for ovarian cancer is HER2. Now, you all have probably heard about HER2 previously because it's an important biomarker in breast cancer, and we've been known about HER2 for years. So Herceptin has been, or which is the brand name for a drug called trastuzumab, has been used for HER2 positive breast cancer patients for over 20 years. About 8 years ago, we realized that there was probably a reasonable use for this, not just in breast cancer patients, but in certain subtypes of endometrial cancer patients. And ultimately, a new, again, antibody drug conjugate, which has HER2 as the target, was evaluated in many tumor types in a trial called the Pan-Destiny trial. And that drug uses HER2 as the target with a chemotherapy payload that's called a topoisomerase 1 inhibitor. And so here's a figure from that trial, and you can see that here are the GYN cancers that were tested, and for all of them, there was tremendous activity actually in both an endometrial, cervical, and ovarian cancer. And in order to be eligible for this trial, you had to have high expression of HER2. So as we showed before, if these are drugs that are going after these targets, the more of that target you have, the better you should do. And that's what they saw. So here's the area for ovarian cancer. And so those individuals with a 3+ on their HER2 did the best of this group, followed by 2+. I will say, though, that this is what we would call a heavily pretreated population, meaning that most of the patients in this trial, this was their 3rd or 4th line of drug. So these response rates are very high. And actually, this response rate for a 2+ is promising as well, although clearly the 3+ outperforms. And that's what we see here as well. Again, those patients with the 3+ are in the blue, with the 2+ in red. And you can see, as we showed in the other plot, that the 3+, not surprisingly, does better from a progression-free survival standpoint, not just the response rate. So this is just to say that we are really at the beginning of a biomarker-driven revolution in ovarian cancer and really in all cancer treatment. And although I've talked about a couple of biomarkers and their related drugs here, there are multiple drugs that are under development now, several of which have gotten fast-tracked with the FDA, meaning that they are being looked at to get to market in a more rapid fashion with various targets. And you can see all of them here. And again, the purpose of this is to use targets that are more likely to be expressed on the tumor than in normal tissue. The benefit there, I've said this before, is ideally you'll have fewer side effects, right? Because the whole issue with chemo, for the most part, is that you're giving it to the entirety of your body. And we would expect that, those cells that aren't related to the cancer, but that you need to stay healthy are also being affected. So if we can direct the chemo directly to the tumor, you should feel better while you're on treatment. So in summary, biomarkers are critical to determine eligibility for treatment. Certainly that's true in frontline. Hopefully I've shown you that with the use of PARP inhibitor therapy, and also in recurrent disease. So all patients with ovarian cancer should get genetic testing for multiple reasons, but also for the reasons we discussed today. And HRD testing, certainly if their genetics are negative. And in recurrent disease, molecular testing is also warranted. Antibody drug conjugates are revolutionizing how we treat patients with cancer. And because they are targeted agents, we need to know the biomarkers associated with your cancer in order to use them effectively. So for now, we have these biomarker-driven drugs against HER2 and FR alpha, but many more are on the horizon and will be available in the not too distant future. Thank you for your attention. I'm going to stop sharing. Great.
Thank you, Dr. Boyd. That was great. So we can start the Q&A. There were many pre-submitted questions, and you can still submit questions in the Q&A section at the bottom of your screen. We will try to get through as many questions as we can in the remaining time. So this person is asking about endometrioid ovarian cancer and whether it tends to be non-HRD.
So actually, endometrioid cancers can be HRD. And in fact, some of the initial trials we think about serous cancers as being kind of the poster child for HRD, but the initial trials for PARP inhibitors actually included endometrioid cancers. And endometrioid cancers have some of the best outcomes in terms of survival if you look across all of the cell types for ovary cancer. So is generally considered a very favorable prognostic in terms of the cell type.
Great. Thank you. And then this person is asking about the new drugs that are being developed to target these specific cancer cells. And would they ever be used as first line, or are they generally reserved for those who don't respond to frontline treatment?
Yeah, that's a great question. And so, yes, the answer is that as these come out, how can I put this? This is more of an issue in terms of how do we safely test the drugs as opposed to where should they be in terms of timing for treatment. And what I mean by that is, we have our current frontline treatment, carbotaxol, which we all know and love, has remained the standard for so many years because, though imperfect, it is very good, right? We know that close to 80% of patients will respond. That's a tremendous response rate. So if you're a drug company, you don't want to go up against an 80% response rate because you may not win, right? And so first you're going to come in where it's a little bit easier in the recurrent setting where you're looking at, if you have a response rate of 20-25%, you may be outperforming some of our current offerings. So you're going to make a window in there first. And then if you're particularly successful, then really what we're looking at is not necessarily replacements, but adjuncts, right? So can we add something safely to the carbotaxol backbone? And is that, and you're right, eventually the holy grail would be if you have X subtype, could we forego chemotherapy altogether and just give you the directed treatment? We are all hoping that one day we will be able to do this, but that will take some time.
Mm-hmm. Great, thank you for that. And then we have a couple of questions regarding people who have been in remission for a while. And in those cases, is it wise for them to be tested to see if they have any actionable biomarkers that they haven't been tested for, or have HRD testing if they never received that either?
Yeah, that's a great question. And what I would say is that if you, like, as I just said, if you've been in remission for a while and then recur, um, then you're very likely to respond again to our backbone, carbotaxol, and we're very likely to reuse that or something similar. If not Taxol, then Doxil, but something with a platinum backbone, because we know you're very platinum sensitive. But I do think, as you saw, there are all these drugs that are coming under development. The only way to know you are eligible for any of them is to get molecular testing. Now, a lot of this is doing right now in the setting of clinical trials. And so every major cancer center, we have many now of these, ADC compounds that are available on clinical trials at NYU and other centers in the city, where, of course, we would test the tumor as part of the trial and then see if you are eligible. But I think soon enough, it will behoove all of us to be getting molecular testing at recurrence to see what you're eligible for. It probably won't change your first treatment. Again, you're very likely to get a platinum, right? Because you're shown that you are very platinum sensitive. But this gives you a sense of what else is available later on.
Mm-hmm. Great, thank you. And then this person is asking about, I guess maybe you could clarify what pieces of this apply to earlier stages of ovarian cancer, like stage 1 and 2.
Yes. This does, so most of this, it's a great question. Most of this relates to, at least we're talking about treatment today, right? And for early stage patients, thankfully, the current treatment we have works very well, right? So stage 1 cancers, we have upwards of 90% survival rate. So we're unlikely to improve on that dramatically, although I hope we make some small improvements there. So, and stage 2 stage 2 is a bit controversial because some people think that it should be kind of moved more into the stage 3 section. And in fact, some of the trials in PARPs did include stage 2 patients. So that you could argue could move in. I will say that from a cost standpoint, there's approval for testing in recurrent disease and advanced stage disease, but not so much for stage 1 and 2. So that's unfortunate, so that's something you should talk to your physician about if you think you're in a stage 2 situation and whether or not that would be worthwhile.
Great, thank you. And I'm not sure if you'd be able to answer this question, but someone's asking about PACT testing and how you can find that outside of New York.
Right. So PACT is the specific NYU test. I believe we are looking at upwards of 800 genes in this test to look for variants that are related to the tumor, right? That we hope some of which will be actionable. But it's certainly, that is one type of genetic screen or tumor testing. There are many others that are not related necessarily to a cancer center, but are more generic than that. If you are interested in having molecular testing at a cancer center, I think you just have to meet with one of the physicians there and they can get that directed. And again, this testing is now covered for patients with advanced and recurrent disease.
Mm-hmm. Great, thank you. And I think we have time for one more question. And this person is asking about whether they should retest their tumor recurrence for possible biomarkers.
Yes, that's a great question. The answer is mostly yes, which is to say that if you look at, we've done several studies on this, and if you look at kind of the tumor at initial diagnosis and at recurrence, they do share a lot of molecular changes, but it's not exact. So, and certainly the farther out you get from the time of when your recurrence is later on, you're more likely to have a different tumor or more heterogeneous tumor. So there probably is benefit to retesting recurrent disease, certainly if there's been a significant period of time from the initial diagnosis.
Mhm. Great. Thank you so much, Dr. Boyd, for your amazing presentation and thoughtful and thorough answers to these questions. We'll have the recording of this program available on our website in 1 to 2 weeks. Please be sure to check out SHARE's website for upcoming educational programs, podcast episodes, and support groups. And don't forget to follow us on social media. Please take a moment to complete the survey at the end of the webinar. The survey will pop up in the browser when the webinar ends, and the link will also be in the follow-up email. All surveys are anonymous, and we really use that feedback to improve our programming. This concludes the webinar. Thank you again, Dr. Boyd, and I hope everyone has a great rest of the day.
Bye.